Good morning, everyone. Thank you so much for being here today. My name's Amanda. I'm one of the PGY3s in the urology program. I'll also be inviting Charlie Chua, who's a physiotherapist, to speak towards the end as well. For today's grand rounds, I wanted to talk about ergonomics in surgery. And I really wanted to talk about this topic because I feel like none of us really care about it. And whether that's because ergonomics sometimes feels like it's common sense, or whether it's because we often underestimate the effects of poor ergonomics and the effects that it actually has on us and our patients. I feel like it's just not really emphasized at all. And for those who might not have met me, I'm like 5'1" on a good day. So I do care about ergonomics, and ultimately, hopefully, after this, you might a little bit as well. I don't know if Dr. Kavanaugh is actually on here. I don't think so,
Yeah,
but
I'm here, Amanda.
oh, you're here. Amazing. Well, I wanted to thank you, Dr. Kavanaugh. I said this before on my grand rounds in surgical regret, but I really want to thank Dr. Kavanaugh. He spent a lot of time really going through these slides and helping me. And even outside of grand rounds, he's been a phenomenal mentor to me. So thank you, Dr. Kavanaugh, for not only overseeing these grand rounds, but also for your tremendous teaching, your persistent patience, and your time and dedication to myself and the other residents. So in terms of learning objectives here, I wanted to define the landscape of ergonomics in the context of urology. I wanted to talk about the impact of poor ergonomics on us and on patients, and then finally talk about different ways of implementing different interventions in the field of urology. So when I was first looking into this topic, I spoke to a few retired surgeons in Canada. And this quote was from a general surgeon. He did mostly vascular stuff, but he developed repetitive stress injury and then a tremor secondary to it. So what he said was, I left earlier than ideal. There were a lot of reasons, but pain and tremor were a large part of it. It was disappointing, demeaning. He did 3,000 of these surgeries and he was the best at it at his center. And then at the end, he felt like he was reduced just to an old man with a tremor. So just from speaking with him, you could tell he was super competent, decorated surgeon, and he really loved the job. He loved surgery. He loved to cut, but ultimately it was sort of a bitter end for him. So just really briefly, the overarching definition of ergonomics is that it's a field of study that looks at how humans interact with system, especially in the context of optimizing overall system performance. And there are several domains that fall under the umbrella of ergonomics. So there's physical ergonomics, and that's the one that we know the most. It has to do with human anatomy, physiology, biomechanics, and things like that. On the other hand, cognitive ergonomics deals mostly with working memory, cognitive load, and how to reduce extraneous load. And then lastly, organizational ergonomics looks at ergonomics on a much larger scale in the context of policies, structures, and things like that. So it's been pretty well established that poor ergonomics do affect surgeons in many ways. So understanding the role of ergonomics is really important in optimizing surgery performance for both surgeons and patients. So the issue is that ergonomics is sort of an elusive topic, and because of that, it's not the easiest to study. And most of the studies take use of surveys, subjective rating scales, it's small sample sizes, single center, and things like that. But here are some of the methods they use to quantify ergonomics. So the REBA is a method. It was validated in 2020, and it looks at body postures or different movements, and it outputs a score that indicates the level of musculoskeletal risk associated with whatever action you're doing. And the higher the score, the higher the risk. The RULA is essentially the same thing, but it focuses on the upper. And there are some studies that use the Borg scale, and that's a subjective rating scale. It's used to assess perceived exertion or discomfort, particularly in muscle fatigue, localized pain. It's been validated mostly in aerobic and anaerobic exercise. In terms of cognitive ergonomics, there is the NASA Task Load Index, and that's a subjective workload assessment tool. It was developed by NASA, and it's used to evaluate mental demand during tasks. And there are other studies that use more objective measures like EMG or heart rate variability to sort of quantify cognitive and physical workload as well. So, what is the impact of ergonomics in urology and why should we care about it? So there is data demonstrating that there is a staggering number of urologists who experience musculoskeletal pain. And they state that operating is the thing that caused their injury, and continuing to operate it just exacerbated it. Over 80% of urologists had pain in the last year, and a fewer number, but still a lot of urologists have pain at least once a week. For urologists, this pain manifests during surgery, after surgery, and it's mostly in the upper extremities, so cervical spine, neck, shoulders, back, hand, and wrist. So it seems like the majority of people are hurting. So what are the implications of this? So for surgeons, primarily, it's affecting how we operate, and second, it's affecting the amount that we can operate. So studies have shown that we are letting our pain and our injury affect our perioperative decision making. It's influencing our decisions on the type of operative modality we use. We're also changing the way that we operate. We're changing the way that we hold our instruments intraoperatively because of pain. So this directly traverses patient-centered care. If our decision making is at all influenced by this need to facilitate our own comfort rather than, doing what's best for the patient or what they actually want. Second, pain and injury is actually limiting the amount that we're operating. So a lot of urologists are using NSAIDs, muscle relaxants to manage their pain while operating. And if they didn't, they found that their operative performance actually really declined. Urologists are getting injured. We're taking time off work. We're seeking invasive treatments for pain and injury, which just means longer time off work. And if you continue to disrespect the principles of ergonomics, pain and injury will bring you and can bring you to early retirement, which essentially translates to serving less of our population. So ultimately, pain is not only affecting our productivity and our longevity, but it's also undermining both the quality and the quantity of our patient care. So looking at the impact of ergonomics on patients, when we try to look at this, we need to look at the interaction of physical and cognitive ergonomics. So poor physical ergonomics translates to an increase in cognitive load, which ultimately affects our cognitive ability in the OR. So to sort of break that down a little bit, colloquially, we can say, surgery is really cognitively demanding. We use a lot of focus. It's really difficult. But there are actually studies out there that aim to quantify this. So this was a study that was done, and it was looking to compare the cognitive loads of different professions. And what they did was they took 21 different cognitive traits from the database from the US Department of Labor, and they combined these scores, did some fancy math, and then combined these scores to make a composite cognitive load score for each occupation. And what they found was surgery was actually one of the highest when it came to cognitive demand. And similarly, really interestingly, if you compare the NASA task load index scores and heart rate variability, it's been used in the industry, in military as a marker of cognitive workload. If you took those raw scores of a vascular surgeon doing a AAA repair during their clamp time and compared that to a pilot's navigating an unfamiliar territory and unfavorable conditions, the scores are actually really similar and almost even worse for a surgeon. So if we think about this, there's really not many professions out there that not only require such physicality, but also require such cognitive demand over such a long period of time. The level of focus, concentration, and attention to detail is extremely high, but also much more sustained than any other profession, unmatched in both intensity and duration. So because of this, it's really important to touch on this concept of cognitive load. So the concept of cognitive load, it's originally from educational psychology. And what it states is that cognitive load is comprised of three different things. Intrinsic load is the inherent difficulty of a task. Germane load has more to do with education, but essentially how the task is taught. And then finally, there's extraneous load, which is how cognitive load is stuff that's completely unrelated to the task at hand. And the goal of cognitive load theory is to reduce extraneous load so that we don't exceed our working memory capabilities. And so there are a lot of studies that look at how we could minimize extraneous load itself when it's related to healthcare and surgery. So these studies have revealed cognitive load to be significantly impacted by fatigue and stress, disruptions or loss of attention, multitasking, time pressures, inefficiency, and also workplace conflicts. So we established that surgery requires a high level of concentration sustained over a long period of time. If you have poor ergonomics, that leads to pain and injury, which thus increases your extraneous cognitive load, which then leads to poor patient outcomes. So if we wanted to emphasize this with some literature, it's almost common sense, but studies have demonstrated that the number of intraoperative errors really correlates with the increase of disruptions in the OR. There was one systematic review that showed that an unoptimized environment, and specifically poor ergonomics intraoperatively, consistently ranked as top 5 as one of the most prominent distractors in the OR. And they also have done studies of surgeons who did experience pain around surgery. And they've been surveyed and reported that their pain was quite distracting to them in the OR. Similarly, pain itself has been pretty well established to be associated with issues of attention, speed, concentration. It affects working memory and affects the most attention demanding memory processes. And we sort of know that already. So how does this affect patients? Well, we've all heard that we've heard the stat that prolonged fatigue can leave healthcare professionals with the equivalency of blood alcohol concentration that's way over the legal limit of driving. So not surprisingly, there are correlations between medical errors and fatigue. Medical error risks have been shown to increase by about 22% when physicians are fatigued. And physicians do self-report errors, and they attribute these errors to fatigue as well. And we're looking at studies specifically related to surgery. Fatigue is obviously more prominent at the end of the day. So if you use that as a marker of extraneous cognitive overload, you can look at studies. There are copious studies that demonstrate an association between longer workdays, increase in medical errors, you have increased complication rates, your patients stay longer in hospital. Similarly, surgeries that are performed at night or after hours or even in the afternoon saw higher mortality rates compared to surgeries performed in the morning. So long work hours, weariness, fatigue that results represent a serious threat to patient safety. And these detrimental effects on fatigue are well documented. So if you take all of that together, that really establishes pain and injury as a construct of extraneous cognitive load. So poor ergonomics causes you to be in pain. It causes you to be tired. If you're in pain and you're tired, doing a job like surgery that demands a certain level of physicality and an incomparable caliber of focus, attention, concentration, you're going to overwork. You're going to overload your working memory, and you're not going to be able to perform in the OR, and your patients are going to suffer. So hopefully we've been able to define ergonomics and why it's important. But in terms of the landscape of ergonomics within surgery and within urology itself, so this was a systematic review that was published last year in the Journal of Clinical Medicine. It identified 32 studies that aim to define the prevalence of musculoskeletal workplace injuries in different occupations. And essentially what they did was they grouped all of these occupational figures and categorized them into 4 different sectors: healthcare, agriculture, industry, computer. Agricultural sector included studies looking at dairy farm workers, rice farmers, fruit farmers. The industry sector had bricklayers, painters, machine drivers, welders, office workers versus computer workers, and the healthcare sector included physicians, surgeons, interventionalists, dentists, and nurses as well. And what they found was pretty astounding. The prevalence of musculoskeletal work-related disorders in healthcare workers was really quite elevated, up along with agricultural workers and industry workers. And the most common pathologies were in the cervical spine, lumbar spine, rotator cuff, and there were a lot of carpal tunnel issues as well. And they also noted a significant increase in these issues by 27% between 1997 and 2015, suggesting there is a rising trend in musculoskeletal disorders in healthcare. And I think it's also important to remember that while, the majority of time when we're not putting ourselves at ergonomic risk in the OR, we're also putting ourselves at ergonomic risk in other aspects. So we're often on the computers, we're documenting. I'm on the EMR all the time, and we're, typing things up. So not going to talk about that, but it's important to keep that in mind. It's just important to mention as well, I think. So it's pretty astounding that within healthcare, the prevalence of work-related musculoskeletal disorders is so high when compared to professions like farmers, coal miners, welders, and such. And the reasoning is not entirely clear, but it maybe have to do with the serious lack of education and discussion, guidelines, principles regarding ergonomics, specifically in surgery. And probably because of this, we are seeing higher rates of injury because of this lack of information. So for instance, if you just did a quick search for ergonomic guidelines and principles that have been established in other sectors, you'll find a plethora of information. However, in healthcare, and especially in surgery, it's really minimal and it's really not discussed at all. There's a huge disparity of ergonomic guidelines, principles, interventions implemented between healthcare and different sectors. And then if you juxtapose this with the lack of disparity between the prevalence of musculoskeletal injury between these sectors, it's really emphasized how behind we really are and how we are really hurting ourselves by not really placing any emphasis on ergonomics. And then there are also connotations here of being an employee versus being a contractor. So as an employee, you're covered under various occupational health and safety regulations, including like the Canadian Labor Code and other provincial acts. And these really mandate employers to identify and mitigate ergonomic hazards, provide training, and consult with employees on safety matters, including ergonomic concerns. On the other hand, whereas as contractors at the hospital, you're not protected. You bear the responsibility. We bear the responsibility for our own health and safety measures. If we're taken out by injury, the hospital does not care. They can and they will find a new person to replace you. So I think what that highlights is, as a group, it's really up to us to understand the context of ergonomics in urology, to understand the impacts, and then try to do something about it. So it's clear that the healthcare sector is affected, the prevalence is increasing. So within surgery and in different surgical specialties, if you just took a look at all of the studies looking at workplace-related musculoskeletal injury or pain across the board in various surgical specialties, the numbers are extremely high, and they're very prevalent in all specialties, with most surgeons experiencing pain and or injury related to operating. The highest prevalence was within gynecology, which does have implications on gender inequity when it comes to intraoperative injuries, but urology is noted to be quite high there as well. So if we wanted to look at the literature in urology, again, there isn't much out there. A lot of them are small sample sizes, single centers, surveys, subjective rating scales. But I think it's still important to survey the landscape of the literature. So within urology, there is this one report from 2009. It was done at a single center in Brazil, and it aimed to look at the effects of laparoscopic prostatectomy on a urologist's spine when they were operating with a trocar on either side of the patient's abdomen. And what they did was they measured the level of inclination of the surgeon's spinal column, which they find as alpha, the angle of alpha here. And their study was really looking to see if using this sort of thin head supporter for the patient would decrease this angle of alpha and therefore improve ergonomic posturing, which it did significantly and changed the practice at their center. But essentially, they used this angle of alpha and calculated the average amount of lean that a urologist had to, undergo when they're doing a laparoscopic prostate. And what they found was the average amount that a surgeon was leaning was 36.1 centimeters, which means that you're leaning a foot's distance for several hours when you're doing a lap prostate. They didn't really look at the implications of this in terms of injury for this particular subset of surgeons, but there are other studies that do look specifically at lap prostates. So there's a study. It was an observational study from 2023 published in the Journal of Surgical Oncology. And it was really looking to compare the ergonomic risk between laparoscopic versus robot prostates. So surgeons were videotaped performing radical prostatectomies, either laparoscopically or robotically. And then they were assigned a score according to REBA guidelines. And the higher the score, the worse the risk. And they also looked at the amount of time spent in high risk categories. And what they ended up finding, not surprisingly, was that REBA scores were much higher for surgeons who were doing lap prostates compared to robot prostates. They also found that surgeons going through lap prostates, they spent a lot of time in medium risk and high risk positioning compared to robot surgeons on the console who were spending most of their time in low risk postures or medium risk postures. And so when it came to other oncologic surgeries, I couldn't really find that much, but there was this one abstract from 2016 from the University of South Florida, and it looked at comparing open versus robot cystectomy. They used EMG studies to sort of quantify muscle fatigue, and none of their data was really significant. But essentially, the trend of their data was that robots seemed to spare the upper extremities, but it was significantly worse for the cervical spine and the back. So if you're considering that transition from lap to robot prostate, you can consider if you want to factor this into your decision. But when you're considering robots, you should also consider your bedside assist. So the position of the bedside assist is really quite ergonomically unfriendly. From my own limited experience bedsiding, I don't know if it's just room 10, but you're often working with really limited space. The monitor is just where you have to rotate your neck. There might be a tiny sliver between the robot arms where you can see the monitor. Anesthesia is breathing in your face. It's so uncomfortable. You're working really hard to just not get taken up by the robot, because there are a lot of clashes that can happen between your arm, the first assist, and the robot. And there's actually a case study that I read when I was preparing for this. It was from 2023 and it was looking at colorectal surgery using the robot. They found an average of 5 clashes per case, and the greatest number of clashes was during stapling and during the anastomosis, which sounds like the worst times for clashes. But this was a study that was administered in 2018. It was from a single center in the Netherlands, from the Journal of Robotic Surgery. And the most notable thing about the study was that they included prostatectomy, and pyeloplasties, along with other general surgery and pyeloplasty cases, gynecology cases. And what they found, not surprisingly, was that the bedside spent most of their time just completely contorted into weird positions. There was around 3 clashes per case, and about 20% of bedside assists had visible bruising or pain from being hit by the robot. Urology scored pretty high in the RULA scores, and they spent a lot of time in sort of static, awkward positions as well. We did score lower than gynecology, which again sort of touches upon that theme of gender inequity when it comes to workplace injuries. In the realm of transplant, there was this one study from 2019 in France, and it sought to compare the physical stresses of 4 different surgical approaches for donor nephrectomies for surgeons and for their assistants over a 33-month period. And what they found was for the primary surgeon, hand-assisted lap nephrectomy had worse scores after 2 hours than the shoulders and arms, which makes sense. It's hand-assisted for a reason. And for people who were doing robot nephrectomy, similar to the previous study, it seemed to spare the upper extremities. So it was way less demanding for the upper extremities, but had worse scores in the lower back and in the cervical spine. And then for the assist, not surprisingly, similar to the other study, Robot assists had just worse scores throughout the board, throughout everything. In BPH, there was this interesting study looking at ergonomics and the prevalence of musculoskeletal pain and injury in endourologists. They found that about 70% of endourologists complained of pain after doing a TURP. And what was pretty neat was they found that the average prostate volume was the most compelling factor and predictor for musculoskeletal injury occurrence. So for endourologists who experience pain, the average prostate size that they were TURPing was about 76 grams compared to surgeons who didn't have pain. The average prostate size that they had was 59 grams. And severe musculoskeletal symptoms were linked to a prostate size of about 80 grams or so. Also for BPH, but for HOLUP, the study was from 2024 from the American Journal of Surgery, and they found that operative time over 2 hours was associated with higher prevalence of pain. Females were about 5 times more likely to experience pain. And interestingly, age and experience were both protective factors for these surgeons. And there wasn't really much for microsurgery or infertility, but there was this one abstract that I found. The authors here, they aim to stratify ergonomic risks amongst infertility surgeons by comparing the standard operating microscope versus looking at an exoscope. And they used Rula scoring and also looked at the amount of time surgeons spent in these high-risk positions. And what they found was, not surprising, the exoscope was favorable in essentially every single way. Surgeons spent much more time in high-risk postures in the upper extremities and the cervical spine when they were using the standard operating microscope compared to an exoscope. So hopefully we've established that pain and injury is pervasive through surgery, and urology is definitely not immune to this. And while as a group we seem to often neglect our own pain, there's actually palpable consequences for both ourselves and for our patients in terms of decreased productivity, decreased longevity, as well as actual patient outcomes. But what can we actually do about this? For instance, with that paper that showed the prostate sizes, you can't just turn away a patient that has an 80-gram prostate and send it to the next urologist, and you can break their back. You just can't really do that. So what can we actually do? So from all of the studies compiled, here's a list of risk factors that are associated with musculoskeletal injury in surgeons. And what we can do is group them separately into patient factors, physician factors, and organization factors, which actually really interestingly mirrors the definition of ergonomics, so physical ergonomics, cognitive ergonomics, and organizational ergonomics. So if we look at these separately, the main issue is that most of this is just non-modifiable. So in terms of organizational factors to do with the job itself, we work long hours. A lot of us are on call essentially the entire week. Just, the past weekend call, that's like 60 hours of being on first call on top of a regular 40-hour work week. We work long hours. There's nothing we can really do about that. We also are forced to go through repetitive motions. We're forced to stand in static postures and have awkward posturing. There's nothing we can do about that either. That's part of the job. We also have really little control over the job. We can't control what walks into the emergency department. We can't control if our patient decides to just eat in the morning, or if they decide they want to give themselves an extra dose of Depicotran because their mood just dictated it. All of these are things that we can't control. It's just part of the job. We can't change that. Not modifiable. When it comes to workplace tool design, I think there are a lot of companies that are now recognizing the importance of ergonomics, especially in the context of increased diversity in surgery. And we can certainly advocate for this, but good luck getting the hospital to buy you new, unnecessary, ergonomically friendly surgical tools. They won't even buy necessary, non-ergonomically friendly surgical tools. And I think that, again, sort of touches on this theme of, the hospital just doesn't really care about us. we're responsible for our own safety or our own injuries. The onus is really on us. So organizational factors, organizational ergonomics, we can't really change that. When it comes to patient factors, there's also not much we can do. So patients who have higher BMI, bariatric patients, we're at higher risk of workplace injuries for these patients. We can advise these patients to lose weight, but we all know that can be incredibly fruitless. So essentially, these are also non-modifiable factors as well, and there's not much we can do. So when it comes to this, it raises the question as to maybe whether as a group, should we consider other measures we can try to compensate for this? For example, I know there are a lot of other specialties, a lot of other provinces that they have fee codes for obese or larger patients. And I genuinely don't know anything about fee codes. So if anyone wants to jump in at the end and like educate me on this, I would appreciate that. But what I do know is that it's really challenging. And again, good luck battling out for a new fee code, which again touches upon this theme is that no one really cares about us as a group. And as a group, it's up to us to advocate for ourselves. So what can we actually do? The only thing that we can change is physician factors. And even so, within physician factors, there are a lot of things that we can't change. We can't change our body composition, our comorbidities, and so on. We can try to exercise more. We can make some friends, have a better social support network, but that's just common sense for good mental health. So to zoom in on the rest of the factors that we might actually be able to actually modify. So the only protective factor identified were age and experience. Surgeons who are over the age of 45 and surgeons who had over 15 years of experience were shown to be at lower risk for sustaining injuries intraoperatively. And what this suggests is that we need more education in this area. So medical students, if you look at the studies that actually aim to quantify the amount that we know about ergonomics, it's really low. So if you couple those together, education should play a larger role. So medical students, residents, we're at particular risk of musculoskeletal injury, and younger surgeons in their 30s seem to be at higher risk of injury. So it seems like during residency or early on as staff is when it's likely most effective and most pertinent to implement formal education surrounding ergonomic principles. Specifically within urology, it's not really been studied. There are a few groups who have implemented didactic curriculums. There are a couple of pilot studies out there that look at incorporating didactic curriculums and intraoperative education by physiotherapists. And some centers have done this. So the University of Miami has implemented a series of modules teaching trainees on concepts of ergonomics. And what they found was that these general surgery trainees, about 85% of them reported decreased injury and pain after attending these sessions. Also, similarly, at the Northwestern Memorial Hospital, they implemented an ergonomic workshop consisting of lecture and also personalized posture coaching sessions with a physiotherapist for general surgery residents. And they found that the musculoskeletal symptoms improved in about 82% of residents. So it does suggest that there is some utility in having some sort of formal training early on during your career to prevent this injury. So intraoperatively, these are some ergonomic guidelines that were put out by Johns Hopkins and then recapped by the AUA. So it's specific to urology. And it seems, almost common sense, but first, table height. For open surgery, table should be around 2 to 4 inches below your elbow height. When you're doing endoscopic surgery, lap surgery, the target working area is between your pubic symphysis and your umbilicus. Your elbow should form about like a 90 to 120 degree angle. For monitor position, the monitor should be directly in front of you. You should not be rotating your neck. It should be about 2.5 to 4 feet away, and the top of the screen should be in line with your eye level, and that facilitates sort of like a downward gaze when you're working. If you're a robot surgeon, sounds like you just really got to watch your back, but essentially your thighs should be parallel to the ground. The thigh torso angle should be 90 degrees. Your knee should be extended 90 degrees or greater. Your elbow should form 90 to 120 degree angle with the biceps here. And then your lumbar spine should always be against the back of the chair, and you need to save these console settings. Other things to keep note of is supportive footwear, compression stockings, sit while you're operating when you can, use anti-fatigue mats, use self-retaining retractors when you can, try to wear two-piece lead aprons when you can, and if you're using loops, use ones that are actually fitted and are light. So these are some principles, ergonomic guidelines that have been suggested for urology. In reality, it's really hard to really adhere to these. So if you're a center that's using like a C-arm or something, your monitor is automatically displaced and you're forced to rotate your neck when you're working. And the table has to be a certain level to actually accommodate the C-arm. So when the C-arm is in there, the patient's penis is actually at the level of my face. And I'm standing on my tippy toes while concurrently using the foot pedal, and both of my arms are in full extension trying to do this ureteroscopy. There's some things that you really can't do, but I think it's important that we recognize that there are principles and just keep that in mind when we're operating. And then what else can we do? So intraoperatively, to reduce cognitive load, there's this concept of micro breaks. And what it is, it consists of less than 1 minute pauses every half an hour or so. And it's been shown to reduce fatigue, musculoskeletal discomfort, especially in the shoulder, the hand, the neck, and the lower back. It's been shown to increase mental focus and physical performance of the surgeon. So for instance, there was a study that was looking at surgeons cutting a shape with some METs, and they found that there was a 7-fold decrease in the amount of errors among surgeons who took micro breaks. And most importantly, it found that there was no significant difference in operative time when micro breaks were taken. So obviously use this in a smart way. So you're not going to be like halfway through your DVC and be like, oh, I'm going to take a micro break right now. But if you do use this in a smart manner, it's shown to do good for discomfort and it doesn't delay your surgery. So we can think about incorporating this into our daily practice. So if we wanted to look at perioperatively and things that we can do, I wanted to invite Charlie Chua, who's a physiotherapist at UBC. He's kindly agreed to join our grand rounds to share his experience and expertise with musculoskeletal injuries and provide just some tips and information on what we can do to preserve our body. So Charlie, it is all yours. Take it away.
Yep. Hi, everyone. My name is Charlie. Just before I begin, my audio is good right now?
Yeah, it's great. Thank you.
Okay, sweet. Yeah, thanks, Amanda, for inviting me onto this presentation. I'm just going to share a couple of things in terms of the physiotherapy role, in terms of educating, prescribing exercise in the hopes of preventing workplace injuries and also reducing ongoing pain and symptoms related to your work, related to your occupation. And in the case of surgeons, a lot of it is kind of related to prolonged postures and biomechanical loads in these prolonged postures. Yeah. So just to start, to introduce myself, my name is Charlie. I work at 2 locations in Vancouver and Richmond. I work in the UBC Physical Therapy Research Clinic. It's a student-led clinic that has students from the UBC program and around Canada that go through their placements there. So I do a hybrid role there where I treat clients that come into the clinic, but I also supervise students that are on their clinical rotations. And then I also work at LifeMark Sport Medicine at the Richmond Oval, doing general MSK treatment there in the private clinic there. Yeah. So to get started, we're first going to talk about some problem areas that I see personally, and these are usually with healthcare workers, especially nurses that I work a lot with. Lower back injuries, oftentimes these are not just from prolonged postures, but also from having to do transfers that are maybe too heavy for them, or they've been doing long hours and general fatigue has built up. A very common one seen in clients in occupations that require a lot of prolonged posturing is neck and upper back pain, shoulder injuries, and as well as wrist injuries, things like carpal tunnel or sometimes even radial, TFCC tears and things like that. Yeah. We'll go on to the next slide here. So what's the role of physiotherapy, and usually what do we do in a session to help clients with this issue? So one big thing, I think this is the biggest thing that we do is education. So it is important to understand ergonomics. It's important to find efficient ways to stand for long hours at a time, sit for long hours at a time. And the goal is to find positions that reduce biomechanical load when operating as much as we can. It is important to understand that it's not a one-size-fits-all approach, okay? People have different anatomies, fitness backgrounds, sports backgrounds that kind of play into the risk of getting an injury related to prolonged posturing, and their tolerance to prolonged posturing as well. So taking into these factors, the goal of an assessment and things like that during a physiotherapy appointment is to figure these things out, really work with the client to understand these differences, and then what can we do to help them understand their own biomechanics and help them find a comfortable position that works for them and that will allow them to maybe reduce the risk of prolonged posture, pain, and injury. So we sometimes do a movement screen or chat to them about their workplace setup as well, so that we can understand what we can change to help them increase their efficiencies and ergonomics in the workplace. So once we've done that, even by finding and maximizing an ergonomic posture, ultimately, if a posture is held for hours on end, as Amanda kind of talked about already, like usually 2 hours plus 3 hours, 4 hours. No matter how good your posture is, no matter how efficient it is, you're still going to be ultimately in some discomfort, pain, and potentially injury. So I always tell this to my clients, like, just imagine one of those like guards standing outside of Buckingham Palace, like ask them how much discomfort they're in. You're probably in a lot of discomfort. So usually what I tell people is that movement, trying to like break up postures and move more is so important. And this is where the micro breaks really come in handy. So yes, Amanda kind of talked about it more in a cognitive load standpoint, but that's a really great opportunity to also fit in some different movements that break up your posture that you've been holding for so long. And that's like the timeline that Amanda talked about, 20 to 40 minutes, is exactly what I tell most people too. It's like within 30 minutes to an hour, 40 minutes, ideally set a timer that's going to remind you to change your posture, move, and just come out of that posture and do different things and expose your tissue to different stresses. It's really going to like that, and it's really going to reduce those symptoms of discomfort, pain in joints and muscles. Obviously, as Amanda already talked about, don't do that while you're halfway through something super important. Do it at an appropriate time, obviously. So yeah, I always tell people the best posture sometimes is your next posture. So it's about movement. It's about changing loads to tissues. It's about exposing your tissue to different stimuluses through your workday. So explore your body's full range of motion every once in a while is going to really help reduce those symptoms and pains related to being in a specific posture or position for too long. Exercises. This is the big thing we're known for. So we actually do not fully understand the mechanisms in which exercise can actually prevent workplace injury, especially in occupations that are primarily in prolonged postures. What we do know is that there is some good evidence that individuals with a more active lifestyle outside of their work tend to experience less ongoing pain and symptoms related to the occupation. So incorporating a routine or an active lifestyle is not just good in this sense, but also improves other measures of health. And there's ultimately there is no perfect exercise. So what I tend to prioritize is what is convenient for the person, um, what their background is in terms of fitness and movement. So if they enjoy playing a specific sport, how can I get them back into that sport? How can we strategize ways to fit that into their routine? And also their current ability to move also factors into what exercise I would choose, and accessibility to being able to do these exercises. So do they have access to a gym membership? Do they have certain weights or exercise bands at home? Can they do some of these movements at work? These are important factors to take into account when we choose exercises to do. Yeah, so the ultimate goal of what seems to work is exploring full range of motion and keeping the spinal musculature and tissue active through those full ranges, through the person's available range, is what I usually tend to base these exercises around. When we allow the body to move through load, through a different variety of ranges, it tends to build a little bit more resilience in those postures, and it also exposes the body to different stimuluses under load that may help with reducing symptoms of prolonged posturing. So, yeah, there's no perfect exercise, but there is some general ones that I like to give out, and they obviously with different modifications. So you can see them on your screen there. Just for the lower back and the mid T spine to lower T spine region, I really like Jefferson curls. So there's a lot of myths about lifting with straight spine or a flex spine. Based on the current research, there is no big differences in injury rates when we lift things with a flex or a neutral spine. It seems to be that how fast you progress with load seems to be a bigger factor. So Jefferson curls is really a really good exercise because it exposes that whole spine into flexion with a light load, right? I always tend to start people out with lighter loads and then slowly, progressively increase that week on week or month by month and stuff like that. But ultimately, the goal is to just expose those tissues, those spinal erectors, the small rotaries and multifidus muscles to some level of light load through a full range of motion. So progressing with weight and progressing with increasing range of motions through over time is going to be important with this exercise, but it's a really great exercise to and people often actually say they feel really good. They feel really good stretch, especially when they try to explore more range into flexion. Another very easy one and one of my favorites to give out most of the time is the cat cow or the cat camel. So you can see that in one of the pictures there where you're going into full flexion and extension on the ground. You can also do this on the chair. The T-spine wall extensions is also a really great one. That's the one that you can see the person doing on the right, basically placing your hands up on the wall and you're going into like a cat camel position, really gets the upper T-spine and neck region. And just for the shoulders, use to fire the traps a little bit more and the muscles connected to the neck and the scapula. Full lateral raises, full range lateral raises are a really good one. Light loads, full range of motion over the head, slowly lowering down, firing these muscles, forcing these muscles to pull on the neck insertions also helps with neck stability as well. So these are some general exercises I like to give out. It's something for everyone to try. Yeah. I think that's probably the end of my little presentation. So if there's questions, I'm happy to answer them, but I'll pass it back over to Amanda. Yeah.
Thanks so much, Charlie. That was great.
Yeah, of course.
So that's pretty much the end of the talk as well. So Just to recap everything and in conclusion, as a response to these learning objectives that I put out up front. So poor ergonomics has palpable consequences for surgeons in terms of productivity, our longevity, our cognitive ability, which ultimately affects our patients and our patient outcomes. So we characterize the pervasiveness of pain and injury in surgery. We looked at the landscape of the current literature in urology and defined some risk factors. And then we also talked about some ergonomic guidelines and interventions that we could actually do, ultimately in order to serve our population as physicians and surgeons. So that's all I have. Thank you everyone for listening. If there's any questions or anything, that would be amazing.